Lieutenant Eric Courtney, assigned to Rescue 64 over here. They're currently building our station on the north side of Jacksonville. Station 64 slotted go in at Dunn Avenue and Harts Road. This is my engineer, Michael Klinger. Both of us have about 5-6 years on the job. I used to be a JEMA member a long time ago, probably about 12 years ago. I was in JEMA for about 4 or 5 years before I came to the fire department, so I just kind of wanted to give back to you guys and show you all the rescue and what we kind of do. Who here actively rides with the department calling the station? Majority of everybody here, or is it just Jack Games?
As much as we can.
Much as you can? Okay. Okay, so if anytime you guys want to ride, obviously with JFRD unit, call the station up, speak to the officer. Those of you that go through paramedic school or want to go through nursing and see some more advanced stuff, you're welcome to come ride with us. And what this essentially was is Chief Powers approached our medical director about 2 years ago and wanted to expand JFRD's capabilities in the field of EMS. When it comes to EMS and 911 transport, in the late 1960s was the first time we had rescues on almost the entire country, right? You had emergency come out with the LA Fire Department, and around that same time, JFRD started a rescue service. So we started off really strong, and then we kind of waxed and waned, and rescue kind of got just kind of mediocre for a couple years. And so they're trying to expand our scope of practice and allow us to do a little bit more. So if you want to come over here to the side, we'll go to the sliding glass door, and I'll show you all the rig. Our biggest thing that we have here has been pretty successful. We're one of the first fire departments of our size to carry blood products. So we can actually administer blood in the field for patients bleeding out. And our protocol says a heart rate over 120, systolic blood pressure less than 90, so signs of shock, right? We can start with a 500 milliliter bolus of normal saline just to increase our blood pressure a little bit, and then we can go with plasma and blood cells. There's no department in the state of Florida that's doing this right now, so this is big stuff. We've only been doing it since October. There's some agencies in North Carolina, South Carolina that are doing it. We've got a special lithium-ion battery pack that'll hook up to this and warm it up to body temperature as you get it. Our dispatch system is, we're currently a 2-rescue station, so we've got Rescue 63 in our house, and then us being the second one, and we kind of rotate calls. If there's anything major that happens, they'll send the critical care truck on like prolonged extrications, house fires with potential patients trapped inside, and we just have a little bit more capability. We have a ventilator in here too, so if we get a patient intubated, or whether it's ET tube or get a king tube on them if we have to, we can put them on a ventilator, and we don't have to stay there bagging the patient, right? So I don't know if anybody's been on scene of cardiac arrest yet, or someone you're bagging, you're just kind of a muscle memory, you're just kind of squeezing that bag. So we have a ventilator, we can control their respiratory rate, their tidal volume really well, and have better outcomes for that. So in addition, we carry some. So this cooler right here keeps the blood at 4 degrees Celsius, and we've got a Pelican box in here for medications. We carry for your paramedics, still Tiazim and Partizim for your AFib RVR. And then we carry some neuromuscular blockers and some paralytics to help us intubate patients. And then anything, the blood on our side, ventilator. We carry IV pump.
Three channel pump.
It's a one channel pump. It's a quantum, a sapphire pump. And the reason that we carry IV pump is that JFRD is kind of taking the burden of doing what's called interfacility transports. If any of y'all work for Liberty or Century, and you get called to an ER for a patient having a stroke, a lot of times private ambulance may not be available right away. When I first got into this field, the fire departments were not hiring anybody. So you would sit on a wait list for 4 to 10 years waiting to get picked up by the fire department, and you work private ambulance. Nowadays, they're so short on people, they don't have as many trucks in service, so they're calling us to transport these patients from standalone ERs to main ERs. And this truck will go to those if the patient's ventilated or on certain IV drips that we can transfer it over to our pump, and we'll work on it. So I just kind of wanted to show y'all, I know in JEMA, I got my EMT, my paramedic first. I never went to fire school. I wasn't really interested in it at first. And then I started doing ride-alongs, the fire department, doing the JAG games, and meeting different crews, a lot of different personalities out there. But there is a path if you like the medical side of things, you like rescue, then if you want to go to fire school and do your time on an engine or a ladder company, ladder guy at Station 7 downtown, and then eventually transition into the medical field. This is a great route to go. This is the cream of the crop of medicine, what you can do. So we can, by all means, we can jump back here and look at it. Does anybody have any questions at all? What's up?
What kind of Gary?
What's up?
I was just going to ask, so let's say we're working a med team at some event, maybe it's at the beaches and stuff. What sort of criteria might we want to get on the radio when we're calling for a unit and say, hey, I want the critical care truck?
So response times are kind of an issue there. So they only have 2 trucks in service right now. This is the one on this side of the river. Rescue 75 is on the west side of the river. And you can come out off the gate if you know, like fall from 20-foot height. Say, hey, we're going to request a critical care unit. And they'll dispatch us to this side of the river, or whatever unit is closer. But the problem is if there's another rescue on scene, like they're not going to delay transport. You know, if we arrive on scene, the couple times that I've given blood in the field or we've RSI, there's been a patient in the back of another rescue. We can get on scene and just like a flight crew, right, if Trauma 1 or Life Flight lands, we kind of get a pass down, do an assessment, and we transfer care to this unit. But again, we don't want them waiting. They're still trying to figure out some, kinks, so we got to be kind of dynamic with it. But call us as early as possible. There's nothing a fireman loves more than get canceled, so, especially at 2:00 in the morning. But yeah, if it sounds like it's going to be bad, then call us.
Especially for medical calls.
What's that?
Especially cancel for medical calls.
Oh yeah. 2:00 in the morning for a call. Yeah, cancel me all day. Yeah. So, you were asking about our event? Yeah, so AHP 300 is very basic. It's kind of a boat anchor, to be honest.
It's a good transport.
Yeah, I mean, it's really basic. And that's our medical director wanted to get into this, and we're just taking baby steps, and then we're going to progress it as we get more involved with it. So, ventilators may seem intimidating. Like I know when I was at Century, my EMT partner knew more about the ventilator than I do because they just did them all the time. A lot of them are pretty straightforward. This particular unit, I think we're probably going to change our bid in another couple of years. This company's kind of might have gone out of business or something, so we need to look at getting different bids.
Is there like AC volume control?
What's that?
Is there like AC volume control?
Yeah, that's what our medical director wants for all our freshly intubated patients. AC volume, and then we may go to like a pressure control or something like that if we have to.
All those here.
So a system control volume where we're just giving you a set tidal volume and rate, and we just put all our data in there and it'll do it for us. Or we can do like a pressure control where we're actually setting a pressure versus a volume. It can get a little technical, but like a patient who either got low 2 sats and very difficult to oxygenate, we can't get their sats up, we may want more pressure than more volume. We got a lot of nurses that are on the team, at least. We got a respiratory therapist. That's our program manager. I'm a nurse. I think there's one of the nurses. There's a website truck. Again, medical. There is a path where you can go. That's what you're interested in with the fire department. So.
One more protocol question, Zach.
Yeah.
Let's say I'm, for example, Rescue 55, and we have a critical care and we do a transfer or intercept. How exactly will that work? Are the stretchers interchangeable? Will we switch stretchers?
Most of the time, that's how it works. Is we just swap stretchers. So we had a patient who was in a motor vehicle accident a couple weeks ago on St. Augustine Road. Super combative. So he's in the back of Rescue 62. And we get on scene. The rescue chief tells us to go over there, help them out. And we just took that patient out of their rescue and put him in ours. But the actual intercept that you're talking about, like if a unit goes en route to the hospital, at this point in time, we're not going to meet them en route. They will take their transport. So maybe down the road, there's talks of either putting us in like a quick response vehicle, like a Tahoe. They may get us like a 3-man rescue, like you have an extra engineer on here or something like that. That might be an option.
Intercept right here, we knew it was
yeah, so like we used to fly like the majority of the fire department. This is the only truck that carries paralytics. Right. So we carry acetylcholine, rocuronium, and every other rescue only is sedate and intubate. So combination ketamine. A lot of times they may not be able to manage an airway adequately without the drug. So they've had a lot of good outcomes with this. We've given blood twice. We've intubated our side like 3 or 4 times. Pretty good. Yeah.
For that question, they don't want us to be on a crutch for everybody else, so they don't want you calling us to do what you could otherwise do. So, every every truck should be able to handle it. And we don't want to stop you, like you already said, we don't want to stop the transport to wait for us to do what we need to do.
Right.
And did they make a separate like SOP for
Yeah.
care?
Yeah, so our SOG 430 covers all of our EMS SOG.
Right.
At the very back of it, they added a supplemental section for all the
Okay.
stuff that we do. Every member of this team has to be a paramedic. 2, we have to be credentialed by the IBSC as an International Board of Specialty Certification. The critical care paramedic exam is what we have to take. If you're in flight, it's a flight paramedic exam. They have other stuff out there for, you need to have like a community paramedicine or a tactical paramedic for like your SWAT officers and stuff like that. So everybody here is credentialed and been proven to, want this job. So right now we're actually looking for a lot of people within our department to be on this team. They're going to open up 2 new trucks this year, and we need a lot of engineers. Engineer is kind of that rank where you have 2 pathways. You can either go suppression route or you can go rescue. And a lot of people want to go suppression. So if you were hired by the fire department in the next couple of years and you were able to make the rank engineer, you could very easily be on one of these trucks because it's something that we need people to do. So.
You will have to do 1 tough year at least.
Yeah,
Now actually you have to promote. There used to be a what they call a third man. Sort of like, they got rid of it, but that used to be a track where you could do your rookie year in suppression and then choose the medical side. Now you actually do have to promote to engineer before you get that. So you will have to do some time in suppression to make sure you want to do that.
What all sedatives do you guys carry?
So sedatives, etomidate, ketamine, Versed, and for anesthesia we've got fentanyl. So most of the time if we intubate we're using etomidate or ketamine as a conducting agent, and then we can take stuff to raw based off the patient presentation or their history.
Just on, because I have people asking, and we're just so you know, we're now assigning people to rescues.
Okay.
I have a lot of people. Obviously, you're always allowed to go trial a new rescue, but to be assigned to one of these critical care trucks, because I have been asked that already, you do have to have a skill set that makes you an asset to the truck. To actually be assigned to the truck, you have to be. You can ride with the truck, like you can call Lieutenant here and ride, but to be assigned, to have that in your fears.
One thing we're doing until the new, we're trying to assign members, JEMA members, to a primary truck and a primary officer, so they can build a rapport and familiarity.
Okay.
I mean, they kind of like how we're doing it, they can still go around with the primary assignment.
Okay. Yeah, that's good. That's a good way to bring it forward. So, yeah, when I was in it, it was very free.
Yep. Just go out there and
go
find
wherever
somebody.
you want and call and all that stuff. So, y'all are welcome to look. It's a brand new rescue. I mean, the interior of the rescue is the same as all the new rigs. They gave us the same rescue with more equipment, so we had to make do with what we had. But you're welcome to see the layout of it if you want. And if you got any more questions, feel free
Any
to.
other area accounts since you are assigned?
Yeah, we have the CMAX learning scope.
Okay, so that guy.
Yeah, so $10,000 fancy.
That's a lot better than the Glidestone.
Yeah. So, for you paramedics, it's a learning scope with a 1080p high definition camera at the top. So you literally put it in like a traditional method you would learn in paramedic school. You just got a camera on the top of it. It's really it's the same equipment they use in operating rooms. The company Storks, Carl Storks, makes a lot of anesthesia machines. Do you work with them a lot at all in the OR?
I did when I was in the OR,
Yeah. So it's the best money can buy for free hospital anesthesia.
Pass it around or
Don't
don't drop it. It's not worth it.
Yeah, $10,000. So just be careful. I promise. The blades are disposable, so that blade's clean.
No pressure.
Yeah.
Hello.
Y'all carry like hyperangulated blades or is like
Yeah, we got one D blade for your real anterior airway and everything. You get with Howard if y'all ever want to do a ride along with any of our trucks at all. Feel free to reach out and see if we can schedule something. So.
Are y'all doing any of the other like facility stuff or like some of your more like patient stuff like ECMO?
No, I don't think we'll ever end up doing stuff like that, to be honest. Like, our plan here in Jacksonville with the layout of the standalone ERs and hospitals, an ECMO call would have to be someone like the U.S. ground truck, maybe Mayo Clinic's ground ambulances. I don't see us really doing that with this. Now, you never know what you can see. Like, that Rescue 72 landed, well, they didn't land, but basically a military Seahawk landed with a patient on ECMO in an open field right behind their station, and they transported an ECMO patient to the ICU. You could see something like that every once in a while, I imagine, but not routinely. For us, it's like really a house ticket to patient. Are they ventilated? Then we're going to go. If they're on a norepi drip, a nitroglycerin drip, or something like that, then we might end up taking them. Most of the time, they'll send the closest rescue. You know, this time is brain with your stroke alerts, right? If a GCS of 15 patient who's got a subarachnoid hemorrhage of the size of a penny, you know, the closest rescue to take them. But you know, you got someone who's herniating who needs to go to the OR, you know, who's on multiple drips and intubated, they'll probably call this truck.
And will y'all ever transport, like, the only way I can think of is a burn unit down to Gainesville, or?
That's kind of a gray area. So like our transport times in Gainesville are so long that the patient should be flown no matter what. If nobody's flying, it should be private ambulance. They really can't find a private ambulance, and I guess theoretically they could call us, but the medical director doesn't want us going that far, because then you're dealing with, especially with an intubated patient, you're dealing with sedation that we don't really do a lot of. Like, we don't do propofol drips on here, ketamine drips or any of that stuff. So,
The price might not percent enough that long to transport.
yeah. I mean,
For now.
yeah, that's long transport. You're doing, you know, not every team member may be as comfortable taking that propofol drip or something like that. So we're taking a nurse no matter what. We're taking a nurse. Why are we taking a critical care truck? Because that other unit could take a nurse anyway.
Right.
So it's theoretical, but I don't really see it happening.
So y'all will take, like, say, someone from some facility that you're transporting to, say, like, patients on a purple trip, or anything. Well, it's like y'all's protocols require that nurse to come with you to manage the purple trip, or they allow
Per
you
our
to do
protocol, yes, but again, it depends on that person's individual comfort. If you get scanning orders from the physician at the hospital, it's like, you know, if you're working for Liberty or Century and you do an inter-facility transport of medications you've never managed before, how are you allowed to do that? Well, it's the sending physician that gives you the orders for it. So we can technically transport anything that the doc says that we can transport, but again, it's that individual comfort level. Is like, if I'm on a propofol drip and my patient's blood pressure bottoms out, do I know how to manage that? Have I ever seen that before? So again, that's where we might have to bring a nurse with us from the ER or something like that to help manage that drip, and we can like monitor an airway or something along those lines. Good question, though. The inner facilities, we've had a post cardiac arrest Baptist teachers, the Baptist downtown that they got Ross on was a STEMI, and we took them to the ER, and they were going to straight to the cath lab from there. And I've had a couple brain bleeds. We had anything else? We had strokes and post cardiac arrest.
As in a facility?
Yeah, sepsis. We had a septic patient on a Moretti drip, like systole above 70 or something like that. Moretti was almost maxed out.
Yeah, do y'all carry any prisoners?
Carry Norepi. Well, so every truck in the city carries dopamine, which is the, you know, bane of every paramedic student's life, right? It's a very technical vasopressor. So the new actually, it's an old school drug that's now in favor is norepinephrine, so Levoped. So we carry that. We have to mix it in the back. We have the vials. So. We carry TXA, which is almost on every. You go to any other city or county fire rescue, they'll be carrying TXA. It's been around for probably 10 years now. So it costs like $1.20, but it's a medication you put in a 100 bag, and it basically prevents clots from breaking down. Be a little technical antifibrinolytic, prevents pathogen from breaking down fibrin. You'll learn about that here, I promise.
So the number of medicines that are carried on a typical rescue, how much more do you carry on a close care?
6 or 7?
Yeah, 6 or 7.
Yeah,
The biggest issue is the refrigeration. So you can get rescue units with refrigerators built into them, like some departments have that where they store their drugs, but no rescue with JFRD has that. So we originally were given a cooler that broke within like 2 weeks. So now we just keep the medications in with the blood, and it has no issue at all. So,
You count the blood and plasma, I think it's only 7.
Yeah.
So we have different usages for some of the ones that everyone else carries. Like we have different usages for ketamine, different usages for nitro.
Yeah.
Nitro's good.
So like a regular truck can't use ketamine for sedation, but we can. We do like a 1 milligram per kilogram for like hypertensive patients post-intubation. Right. So, why?
Sympathetic storm.
Yeah.
I don't think that's enough.
They can knock them down, but they can't sedate. So. I know for some of you EMTs, I remember being EMT and like it sound like it's up here, but you're just a tip of the iceberg. When you go on paramedic, you learn a lot of this stuff. Even when you get to paramedic, I remember being a baby medic graduating. I was like, I do not feel like I know what I should know to do this job. And I remember being 21 years old, working at Century, working with Darren over here. There's a lot of it was fake until you make it.
Two of us.
So, but I mean,
We did a couple of that runs.
yeah, I'm sure you knew more about it than I did at the time. No doubt about it. So, I learned a lot from that job.
Well, I'm newer on the medical side also, and this truck has all this fancy stuff that we talked about, like you're asking paralytics and pumps and all that. It's super easy, like when you're new on this, to forget about like your good trauma assessment. If you go on an education, we're thinking like I'll immediately start thinking we're giving blood, we're knocking them down, we're doing all that, thinking all that stuff, and then I'm counting on some engine dude who doesn't care at all about EMS to do the assessment, to do like the physical assessment. He's not going to do.
Yeah.
You got to know that, right? So that I did. It's always the basics first. For sure.
Yeah, especially when it comes to airway management here. Good BLS, and then we'll add a little bit of ALS and a little bit of critical care on top of it. Good. It's a good start, I'd say, for trying to progress EMS as you guys know. So, there's plenty of opportunities out there to keep on learning, whatever your career path is, whether you go nursing or go to medical school. If you're not doing something totally unrelated, when it comes to this stuff, there's plenty of opportunities to learn out there. I advise you to find like a mentor. There's all sorts of classes. US got a EMS conference coming up in June. June 16th or so there you go. It'll be a good experience for you guys. Get a chance to go out there.
I know a lot of like flight programs are trying to progress that. Is there any talks with you guys to start?
There was talks about it. I think there is some utility in it, but like the problem with ultrasounds is one, like we're not gonna, we do a fast exam for our trauma patients. We do a quick exam of the abdomen to look for any type of bleeding, right? That's not going to change what we do back here. We're still going to see either tension pneumothorax physiology, we're still going to see shock physiology in our monitor, and we should be treating that without the ultrasound. And we're not going to, if a patient we think has had like a medium mechanism of injury where they may need to go to a trauma center, like our negative fast or positive fast shouldn't change our destination. So it doesn't really change our treatment. And then as far as IV access goes, it works great for IV access, but you have to have the reps with it. You got to be a super user in order to get that 14 gauge in a AC within less than 15 seconds with the ultrasound. And to get those reps would be a lot of time to get that proficient. So we may get to it eventually. There's a lot of grant money for it. We may get it one day. There's a trial run, but I fly with Trauma 1. We carry ultrasounds, and I mean, even the Trauma 1, the transports, you don't really use them.
15 seconds.
Yeah. I mean, I've worked at Memorial in the trauma bay there, and like we got nurses that could throw it in, get on the ultrasound, throw it in, no problem. But like to get those reps, I mean, you guys be doing like 100 to 500 IVs.
It's like with life support. It's a different anti.
Yeah, and you're looking at a screen to do an IV, and our guys, we're not used to that. We probably have to put our guys in the hospital if we are going to do reps. So I think there's utility in it, it's only for IV access, because we have yet to encounter a situation on someone who needs blood products and we can't get a line. If we can't get a line, we're going to IO them, usually in the humerus, right? Humeral IO flows the same as an 18 gauge IV. So that's a good way to go about it, but then at the same time, how long is your transport? You're trying to get maybe 600 to 800 cc's of plasma and blood in. Do you have that much time to work with your transport? So I think there's utility in IV access, and you may see it one day, but as far as assessments go, that's a little too far out. When you're a paramedic and you're looking at EKGs, looking at your stents, like, oh, this one's obvious, this one's not obvious. Like, you have to see a lot of normal ones and a lot of not so normal ones. So interpreting the ultrasound screen, I think that would just take a lot of time.
Unrelated question, changing the subject a little bit. As an alumni or alumnus of JEMA,
Right.
we have a lot of people who want to get hired. Is there an opportunity you wish you had taken care of, or an opportunity that you said this really made my job now a lot better? Or
I mean, honestly, JEMA, and it's just more like getting to know the culture of the department and like seeing faces and knowing people. I think that kind of gave me a heads up of what I was getting into. But then, like that rookie year is a totally different experience too.
Yeah.
So we all went through it, and it depends on the station you go. Like Klinger went to 7. He probably had which is a hazmat station, the ladder house. Probably had a lot harder rookie year than I had at Station 32 on the west side. It's just an engine and rescue. So depends on where you end up.
But you came from experience down south too.
I did, yeah. I worked down south for 3 years.
Sometimes it's good, sometimes it's bad.
Yeah.
If you're starting older, I think sometimes the experience somewhere else might hinder you. Yeah, because you got. I mean, there's no way around it. You're a rookie. I started this job older, and you're cleaning toilets. You're doing all the stuff that you cannot be above doing any of that stuff. So you're expected to do it. Like you said, different stations you're going to get it better or worse. My station I didn't think was super bad, but it's kind of an old school, like prestigious station, and they expect things done a certain way, and you need to do it that way. So if you came in with like, I've done this before, I had 10 years on, then you're not going to do real. It's going to be a tough year.
Yeah, that attitude anywhere is not a good idea. So it's like being humble and like, I came in as 3 years of riding, essentially being a rescue officer in another department. You go to Clay County, Nassau County, where I was, Brevard County, you were a rescue officer until you had seniority to get to an engine. So I came in there and, running a charter rescue, didn't really know much of my suppression stuff. But when it came to patient care, I just kept my mouth shut and I took a blood pressure. That's all I did. And up until, I promoted to engineer after my rookie year and all that stuff. And I started, putting it out there. I knew a little bit more than, what I was looking on. But being humble and not being the smartest person in the room is like some good advice I can give you. Be humble and always seek out someone smarter than you to ask those questions to. I tell him all the time, it's like you're around 5 people you can get good advice from, bad advice from, and you just kind of make your own judgment out of everything and come out with the career and employee that you want to be in your career. So.
Well, you got all kinds of opportunities. JFRD is cool. It's a little bit of a hindrance. People promote really fast on both sides, and so spots open up. So if you want to get on this truck, like he's probably
there's 500 retirements happening within this department in the next several years.
Yeah,
so people who want to come, there's opportunity.
There's a lot of opportunity. You do need, the way it is now, like I said earlier, we got rid of that third man opportunity, which go both ways. It's good and bad, yeah. So now you do have to put in time on the suppression side and learn that job before you get an opportunity to go rescue. So just know that going in. I know this is an EMS side, but that first year, because you really have to promote, so it depends on when the promotional tests line up and then where you fall on that promotional test. So it could be 1 year if you hit it right. It could be 4 years. I didn't get a chance to promote until the list came out. I was on the job for almost 4 years when I sat to take my first promotion test. Really 3.5 when I sat for the test. And the list came out, it was right at 4 years. So I was I promoted in the first 2-3 months, but still I was already over 4 years on the job. So if you were dying to only do rescue, that'd be a tough 4 years. I like both sides. So
yeah, you got to be able to do the other side of it too.
Yeah. So just know that that's part of the game. It's fun. It's a completely different job. So that's why I'm having fun over here now. Almost exclusively fighting fire. So one of the busiest truck firefighting apparatus in the city to now with this guy doing the most advanced stuff that we have. It's pretty cool. And then you can once you make that decision to go suppression or rescue, you can do whatever you want. The city's going to pay, or if you want to get your nurse or your degree, any kind of training, like you can build a career within the department as well as help you outside. I don't know if they're going to pay for much.
Maybe medical director one day. I don't know. We'll see. Talk to Dr. Elias, see when he retires.
We've actually been trying to incorporate our medical students or ones who want to go a lot more.
Cool. Yeah, if they're going to ride rescue, make sure they ride on one of these trucks. You don't want to put them anywhere else. Yeah. By all means, man. On it. Well, good time. It's 400 to 500 people retiring from the department within the next couple of years. So there's going to be lots of openings. You know, fire school, rookie year, all that stuff like that. We already talked about
It's
it.
a tough 2 years because the rookie year with the department and then fire school. I mean, you all are at least EMTs, so that's out of the way. But fire school is not easy. It's not terrible. You just have to keep your head down and grind your way through it and get through it if you're just mentally tough. I know it's trying to fail you. They're trying to.
Nobody's out.